So good afternoon, friends. So today I'll be talking on this topic, cytokine storm. So this is in the light of extensive usage of tocilizumab that is happening across the board for COVID, and we see this drug being used quite liberally to almost many COVID patients in district hospitals pretty early on. So I just thought it's good to look into the science of what this whole cytokine storm that we are talking about in COVID context. And this was a good article that came in JAMA. So it came in 20th June 2020 in this JAMA. So it's a very good two-page article which tries to debunk the whole concept of this cytokine release syndrome in COVID. Okay. So the background is COVID-19 mortality worldwide has been reported as 40 to 50% in sick patients. And if you look at the cytokine storm that you typically see, so the virus enters the lung and then it activates the whole cellular mechanisms, and then there is a huge cytokine release. The main cytokines that get released in COVID that has been postulated is interferon, interleukins, chemokines, and tumor necrosis factor alpha. So these are the ones which are deleterious. So what we understand by cytokine storm is there is a pro-inflammatory mediators, and to counter that there are anti-inflammatory mediators. So when there is a overwhelming imbalance between this pro-inflammatory and anti-inflammatory, that is when your whole physiological dissonance happens and organ dysfunction sets in. So there needs to be a reciprocative balance between pro-inflammatory and anti-inflammatory. So it is usually the underwhelming anti-inflammatory response or overwhelming anti-inflammatory response to counter the inflammation which leads to the organ damage. So that's what we have understood so far, which tends to occur either in sepsis or ARDS or any other inflammatory condition. So these cytokines, when there is a disproportionate imbalance, then that is when they start injuring the host cells, when there is an imbalance between the anti-inflammatory and pro-inflammatory. And it is being found that the injury to the cells is not a linear or it is not a uniform mechanism, and it is fairly non-linear and non-predictable. How the injury happens and what sort of an imbalance exists is all depending on your own internal milieu that influences how much damage that happens. And it is also shown that these cytokine storm have pleiotropic downstream effects on various bodily functions. So these are some of the ways that it causes injury. And now the whole question is, why has cytokine storm been so closely associated with COVID-19? So we need to look into evidence whether the so-called cytokine storm that we are talking about in COVID, does it really happen? So that is what we are interested. So the whole hypothesis came from SARS-CoV-1. So the previous MERS or SARS-CoV that happened. Now we are in SARS-CoV-2. So the cytokine storm was postulated in that sort of a disease condition where it was shown to have correlation with adverse clinical outcomes. So this is a very interesting slide one needs to look at. So they have charted down the interleukin 6 levels in COVID-19. So these are all the Chinese studies, as you see, Zhou et al. 191 patients. They looked at interleukin 6 levels. And as you see, the levels was 7 picograms per ml, which is a very not a significant rise. And this is the interquartile range, 5 to 11. So this is in COVID-19 patients. And Wu et al. Looked at 123 patients. This is taking all COVID patients. And as you see, the interleukin 6 rise is not very significant. And Mo et al. Showed 45 and Quinn et al. Showed 21. So these levels, what we need to understand in the whole COVID population was not significantly higher compared to what you would expect. I will show in the subsequent slides, you will understand. So then in that whole population, these authors have also looked into interleukin 6 levels in sicker patients. In this previous slide, what you saw, in 191 patients, they substratified and they looked at non-survivors. When they looked at non-survivors, they saw interleukin 6 levels was not very high, it was only 11. And this is the interquartile range of 8 to 14. And they looked at ARDS patients, means where obviously the lung damage is prevailing, where you would expect interleukin 6 levels to be high. Even there they found levels was not very high, 7. And they looked at refractory hypoxemia patients. Even there they saw that levels was not extraordinarily high. And Quinn et al., again he looked at ARDS, it was not extremely high. So this particular paper which came in JAMA, they have compared this with the previous ARDS trials where they have charted down interleukin 6 level. Previous ARDS means the conventional ARDS that we have seen in other disease like H1N1 or any other condition. So these are the three trials they looked at. Alveoli trial, which is a ARDS trial, FACT trial and SAILS trial. These are the number of patients, and you look at the interleukin 6 levels in picograms. It was much, much higher. So the conventional ARDS which we have been treating had much higher interleukin 6 levels than the COVID-19, what we are postulating it as high IL-6 levels and targeting IL-6 level. So that is where the whole fallacy of using tocilizumab comes. I think that's what you need to appreciate in this slide. And and in this particular trials, they've even looked at two phenotypes: hypoinflammatory ARDS and hyperinflammatory ARDS. Even if you look at hypoinflammatory, where inflammation is less, the interleukin 6 levels were much higher than the COVID-19 interleukin 6 levels. As you see, is 154, 86, and 282. And here you see it is all only in double digit. Okay? And when you looked at hyperinflammatory group of patients, where there is a more inflammation, where you expect very high, so there you see interleukin 6 levels is increased to 100 fold. So as you see, it's 1525, 578 and 1618 in these trials, alveoli FACT trials. So basically our understanding is in the general phenotypic ARDS which we have ordinarily been treating before, in hyperinflammatory phenotypes we have had much higher levels of IL-6 levels as compared to the COVID-19 ARDS. So COVID-19 is not mounting significant rise in interleukin 6 levels to the type that we have seen in our conventional ARDS. That is the point that one needs to appreciate. And as again they mentioned, the ART studies, the alveoli, FACT and SAIL studies showed the median interleukin 6 levels is 10 to 40 folds higher. That pattern we are not seeing in COVID-19. It is high, it may be marginally high, but it is not increasing 10 to 40 fold higher. And even in the ArtsNet study, there was a correlation. When interleukin 6 levels goes up 10 to 40 fold, it was associated with shock and adverse clinical outcomes. And the hyperinflammatory, what we saw, the rise in interleukin 6 is 10 to 200 fold higher in a hyperinflammatory phenotype. And that pattern we are not seeing in COVID-19. And again, they showed when in a hyperinflammatory phase where the rise is 10 to 200 fold, it did not have a correlation with the lung injury. So even in ARDS, although there may be a high interleukin 6, the correlation with the lung injury was not present, was lacking. So there was no real correlation. And again, the authors do mention in this COVID-19 ARDS, what we are seeing in the post-mortem study that was done in the Italian group, they saw that the microthrombi formation in the alveolar level is 9 times higher than our conventional ARDS. In conventional ARDS, the microthrombi formation was not as extensive as what the post-mortem report in COVID-19 patients, because it was 9 times higher. So the microthrombi formation at the alveolar vessel seems to be much higher. So it is more of a vascular problem that seems to have been witnessed in COVID-19. And the whole thought process of using tocilizumab comes from this particular study, 2016, Mod and colleagues. They used tocilizumab as targeting the IL-6 levels, where IL-6 levels were 10,000 picograms per ml, which was 1,000-fold higher. So that is where they have used it and showed benefit. And we are extrapolating this science into using it in COVID, where we know that IL-6 levels are nowhere near such high levels. So this is where the authors, so this whole paper tries to debunk this whole philosophy of cytokine release. So the cytokine release itself may not be existent to the extent witnessed in other studies, and targeting that by using this dangerous drug tocilizumab, which is an immunosuppressant, may be harmful is what an assumption that we may have to make at this point of time, because the evidence doesn't seem to be very strong. So the conclusions the author makes is this is a sort of a very dramatic sort of a jocular imagery, they say, and they say at best it is tempest in a teapot. Tempest in a it's a small event which is exaggerated in a big way. So authors conclude that this is more like a very dramatic imagery with tempest in a teapot. So it's something that should be ignored, the interleukin 6 level. So that is the sort of conclusions that author makes. So it is a very interesting paper to read to understand that the type of IL-6 levels which we are targeting does not seem to be justified in COVID-19 patients. So it is something that we need to look at. So I would think based on this paper, I think we have to be very cautious thinking of using tocilizumab in COVID-19 patients, given the fact that it is immunosuppressant, it can lead to increase in the risk of secondary infections, and more so when the science is telling us that IL-6 levels are nowhere near the levels that that has been shown to be beneficial if you target to reduce IL-6 levels from the previous studies. So just some of the images which came recently. So this is the burden of COVID-19. As you see, the first wave is what we are all dealing with, where patients are acutely getting ill and it is taking a huge burden on the healthcare system. So the second wave would be would be on all the resource limitations that would happen to take care of the subsequent patients. The third wave is on all the chronic conditions, and I think we are already witnessing this fourth wave where there is a lot of burnout syndrome that is setting in the healthcare professionals. So these are different curves that was circulating in the WhatsApp. I'm sure some of you have seen this very touching image. So I think the tocilizumab, you can put it like this. So there is a lot of push to using tocilizumab. So I think we may have to be a little more cautious and be judicious in trying to identify the patient and not to use it as a routine standard of care. So thank you very much.